Prof. دكتور شيكونياك موضوع هو Diabetic retinopathy prevention and screening and treatment. Thank you.
Thank you very much. Yes, I'm opening this session, and the topic I will cover in the next 20-30 minutes is about the complication which is probably the most prevalent besides neuropathy in our patients, but also is the one our patients fear most. If we ask the questions, if you ask our patients with diabetes what are they afraid of, the most feared complication is the one, oh, you can see the mouse here, the one at the top, going blind. The next one is losing the limb, which basically these two means that a person become a disabled one once they develop any of those. But still, going blind is number one fear. Interestingly, we in Europe in general, we see less and less patients who went blind, totally blind, due to retinopathy. They have all sorts of visual impairment, and I will be talking about it, but fortunately we managed to stop people with diabetes going blind, at least in Europe. That's what we, that's what we see. The natural history of diabetic retinopathy is, well, nothing new here. It starts with what we call, it is tricky, we call it preclinical diabetic retinopathy, then a mild stage, then a moderate one. This is where some sort of laser therapy already might be indicated. And then this is what we fear most, a severe and non-proliferative. Proliferative means the ones which develops, the case when patients develops new vessels in the back of the eye. I show you a number of pictures. Or we call it pre-proliferative retinopathy as well. And then the worst type, which is vessels proliferating in retina, proliferative diabetic retinopathy, which forms advanced diabetic eye disease. Across the whole spectrum of retinopathy, patients might develop changes in macula, maculopathy, which is also a vision-threatening complication. If you look at epidemiology, retinopathy for years was mostly associated with type 1 diabetes, and obviously after 10, 20 for sure years of type 1 diabetes, almost every patient has some sort of changes in the back of the eyes. In type 2 diabetes, not as many patients develop retinopathy, but they develop it much earlier. You can see here that 20% of patients in this analysis with newly diagnosed type 2 diabetes already had retinopathy. The difference is clear. The patients we always diagnose type 2 diabetes much later after the disease started. With type 1 diabetes, the period of hyperglycemia before diagnosis is relatively short, usually counted in days or weeks. When we look at those sight-threatening diabetic retinopathy, which is mostly proliferative or macular edema, then type 1 again is the leading problem here. It's the group where these two complications occur more often than in type 2. But again, macular edema is also up to almost 20% of type 1 diabetes patients, but it's frequently more and more often found also in type 2 diabetes patients. Sometimes it's difficult to make a difference. Is it macular edema associated with retinopathy, or is it a sort of macular degeneration associated with age? I said at the very beginning that we see fewer patients with going blind, and the progress has been seen very early on. That's the paper from 2011 showing the decline in severe diabetic retinopathy in type 1 diabetes in relation to the time when patients started to have type 1 diabetes. So all those who started to be type 1 before 1975, they ran a very high risk of developing sight-threatening retinopathy, while only if they started to be type 1 diabetic patients 10 years later, this risk is much, much lower. The reason for that is mostly DCCT results published in 1994 showing that intensive insulin therapy decreases the risk of retinopathy hugely. And the other cause was the increasing introduction of laser therapy in 1970s and 80s. So now I will show you a series of pictures describing what we are dealing with when we talk about retinopathy. That's an example of a regular retina on the left. You can see that this is a very complex structure with a network of vessels on retina, and on top of this there are a few layers of mostly neural cells which are responsible for picture reception, but also vessels going through those layers. They are present here as well. And on the right hand side of this picture we can see severe non-proliferative diabetic retinopathy with diabetic macular edema. And there are a number of lesions here which are easily identified in every fundoscopy in patients with diabetes. So we may find, and I show you more pictures of the microaneurysms, which is an early lesion in the arteries of the retina. We may see venous beading. It's also the dilatation of the veins in retina. The beginning of neovascularization, but very small, so that's not yet developed in the full proliferative diabetic retinopathy, and something we call cotton wool spots or hard exudates. This is the serum leaking from the vessels, which forms that sorts of lesions in retina. They are rich in lipids, then we call them hard exudates. But also in a lower part here you see the cyst full of fluid, and this is macular edema with an immediate risk to cause retinal detachment, because this fluid here between this layer of the vessels and retina is a subretinal fluid, and if it accumulates it may lead to retinal detachment, which means loss of the vision of immediate nature. So now let's go through a number of pictures ophthalmologists usually see. If you were in UK 20 years ago, 30 years ago, you would probably, you could ask every endocrinologist, because the doctors treating diabetes regularly also assessed the eyes. It stopped to be the case because of the changes which were introduced in Britain, a very successful program in retinopathy screening. In other countries in Europe, we usually do not do it nowadays. If we have any suspicions, we refer patients to ophthalmologists. But still, we should be able to know what might be found in the eye of a patient with diabetes. So that's a regular, proper human eye with no changes. There are structures we should all remember from our studies still. There is an optic nerve disc here which doesn't take part in vision formation, and the most important part is here in the middle. We call it the macula. This is where the picture is created, and the central part of it is called fovea. It's a little bit darker than the rest of the surrounding area. We also have the frontal part of the eye with a lens, and this is where cataract occurs. But I'm not talking about the complications of the frontal part of the eye this time. So that's the view of the normal retina with the macula, which is this most crucial part, and a fovea in the middle, the darker one, as I showed you. You'll see the picture of macular edema when the central part, being slightly darker, becomes pale or paler, and that's the sign of macular edema. And there is two sets of vessels. One artery is going to the upper and the other artery is going to the lower part of retina. So this is how it all starts. We may see the arteries with a small dots alongside. This is in a larger magnification, and these are microaneurysms. This is the endothelium, which starts to be damaged by hyperglycemia. Endothelium is 100% non-insulin dependent tissue, so if there is a lot of glucose in the blood, it goes in only depending on the concentration in the blood. It goes into the endothelial cells. they go berserk, they don't know how to handle that amount of energy, they weaken, and those microaneurysms are the first signs of any damage hyperglycemia might cause in the eye of patients with diabetes. That's a more advanced stage. We have small hemorrhages because those microaneurysm might cause a little tiny hemorrhages, all these red dots here. We can't see any new vessels being formed here. It's still a non-proliferative diabetic retinopathy, but clearly a more advanced stage of diabetic retinopathy. And these are the wool spots, which you can also see in the back of the eye. That's the deposits of all sorts of proteins which are in the serum. That's also here, they are visible here, and some small hemorrhages here and there. And that's hard exudates, what we call. They are thick in lipids, rich in lipids, exudates of the serum. The fluid has been absorbed, the lipids remained here. It's also the example of an increased leaking and imperfection of vessels in diabetic retina. There's again another picture. You can see small dots here. They are the lesions. It might require a little 1 or 2 courses of laser therapy already, and there are hard exudates on the peripheral parts of this retina here. And that's the complications we fear most. In this resolution, the screen, you should be able to see at least 2 or 3 sets of new vessels which have been formed here. One is in close to the macula. It's a tiny network of the vessels. The other one is top here, and the third one is at the bottom part here. The mechanisms for development these new vessels, which, as I keep repeating, we fear most, is that because of the vasculature of the eye is damaged, the eye tries to improve the arrival of oxygen to retina, oxygen supply, by creating those new vessels here. But the trick is that all our, it's not me, yeah, it's all our vessels we have in the eyes are being formed when we are in our mother's wombs, when we are fetus, at our fetal age. And later when we are born, those vessels only grow longer, thicker, but there are no new vessels being formed. So anything which is formed later in our adult life in retina are not properly built vessels. They have very weak wall, and they are very much, and you can see it, of a very tortuous course here. And they bleed easily. And that's the case of bleeding from new vessels here. If it happened, the patient see it, the patient immediately realizes something goes wrong with my eyes. If it is in front of the macula, then they stop seeing anything. And this bleeding, the blood goes into vitreal fluid, and it is also not just important because patients don't see anything, but if this blood communicates with retina here and then is being removed by macrophages, because what happens there is what happens with every scar. So if you ever cut yourself, then you see easily that the scar, creation of a scar, means that the proteins contract, the skin is pulled to close the wound. The same happens here. This blood clotted and it contracts later on, and it may pull retina from the bone at the back of the eye, and may be an immediate cause of retinal detachment. So we try to avoid it as much as we can, and we also treat it when it occurs. But at first, when there is a massive bleeding, quite often ophthalmologists decide to wait a few months, because this also could be absorbed and leave little or no sign afterwards. That's a more intensive bleeding. The blood is really filling the vitreous fluid, so it's a vitreous hemorrhage here. And then after up to 6 months, sometimes ophthalmologists decide to wait. The blood might be removed completely, or What may remain are the membranes of fibrous tissue here and here. It is called sometimes gray membranes. They might block the vision, and the patient may still remain even blind with this. And this is treated with vitrectomy. There is no other way like to remove all those membranes, remove the vitreous fluid, and put some new fluid like silicone oil into the eye bulb. And the last complications I want to show you in pictures is diabetic macular edema. That's the picture with hard exudates here, small hemorrhages, but the center, you can hardly see any fovea here, it's pale, and this is an edematic macula in the center of retina. This is the fluid accumulating at the base of retina here. This has been acknowledged relatively recently, like 15 years ago, and it happened mostly due to the invention of this tool, optical coherence tomography, OCT, which is now used routinely by ophthalmologists. This is the tool which allows to create an image of the retina. This is a normal retina, and the fovea is here, this little pit in the middle. And this is the macular swelling, macular edema, accumulation of fluid in the middle of the retina. So this is a painless examination done by an ophthalmologist, and it's invaluable in assessing the condition of retina. There are several types of macular edema which have been identified. This is a sponge-like, when you have fluid accumulation alongside and across the retina. The cystoid one, when we have clear cysts, and the one which leads to retinal detachment. That's the picture we've already seen. So these are the things which might cause blindness, and if we see patients nowadays going blind, but I haven't seen one for the last 10 years at least, it might be due to macular edema or severe hemorrhage to vitreous fluid. Okay, so what is our task? What can we do? How should we go about? While we leave most of the treatment to ophthalmologists, there is still a lot to do for us as diabetologists or endocrinologists. First, we have to screen. And that's a very practical issue. There is a difference between type 1 and type 2 diabetes patients. In type 1 diabetes, when I started to work over 20 years ago, there was a tradition that every patient with newly diagnosed type 1 diabetes will refer to ophthalmologists to assess the retinas. And we've never seen a patient with newly diagnosed type 1 diabetes with any changes in the eyes. Then when I somehow became responsible for patients' management on my own, I stopped doing this because there was no really reason for that. And in this screening algorithm, you might see that screening should be initiated 5 years following the diagnosis of diabetes. The common knowledge is that the patient has to be at least for 3 years type 1 diabetic patient, and the diabetes must be poorly controlled, that he or she requires any changes occurs in their eyes. So you have 5 years if someone's after puberty. Before puberty, it's earlier because of unstable glucose control usually. The Americans also say that you should screen in type 1 diabetes after 5 years after diabetes diagnosis, or when a patient turns 30. So that's another recommendation. What is more important is type 2 diabetes. The patient should be absolutely screened at the moment of diabetes. We always do that. And if the patient cannot have it done while he's at a hospital, when he's admitted with newly diagnosed type 2 diabetes, we usually ask the patients to go to ophthalmologists on their own. They don't need any referral notes and be screened. And then it all depends on the presence of retinopathy. If it is present, if it is mild, 1 yearly examination is enough. But if it's not mild, if it's moderate, if there are some red lesions here, the patient should be screened more often, usually every 6 or even 3 months. In type 2, and there is no retinopathy. In type 2, again, it could be 1 or 2 years. In type 1, in type 2, they say now the discussions in US that perhaps if there are no changes, the patients might be seen every 2 years. But I guess a yearly examination of the eyes is a good practice in diabetology. What I tell my patients is, look, where have you been, when did you go last time to ophthalmologist? And they say, well, now we have November, and let's say they would say, oh, in March. So I say, okay, remember, every March you go to ophthalmologist. Whether you're referred or not, remember, like in my country, we all know that there is a Christmas is in December, so your ophthalmologist is in March. Just make a point like that, because it's largely patient's responsibility. It's not really us who should tell them go to ophthalmologist. It's their eyes, and they should remember about it. One thing which happened here, and it changed the screening in a qualitative manner, was introduction at the beginning of the century in Great Britain, the digital screening for retinopathy. It has now over 10 years duration. That's a national program, the one we all envy in European Union. I must say, when I was the president of Diabetes Poland, our association, we tried to engage the Ministry of Health into this program. It requires some spending at the very beginning. The program is basically quite simple. In every outpatient or inpatient clinic, you put a fundus camera, you put a digital camera, and you employ a person. Doesn't have to, shouldn't be a doctor, doesn't have to be a nurse, could be a specially trained person who perform the digital pictures, does photography of the retinas in any patient who comes to this clinic. And the key for success of this program is that these digital pictures are then sent online to the few centers, or could be one center if the country is small, to one center where trained ophthalmologist quickly assess, is there anything to do here? It's not an ophthalmologist in every clinic, is not necessary. The assessment should be somehow centralized. And persons who are involved in this are also the people who are involved in UK PDS program, for example, like Irene Stratter, one of the leading statisticians there. And with all the difficulties the program had, it is regarded as a success what was managed to be introduced in UK. A similar program works very well in Singapore, but it's a much smaller place and also much wealthier, I believe. But this is something we should all aim for. There is no more the time where all of us could individually assess the back of the eye is past. Of course, it's better than nothing, but you have scarce ophthalmologists. But this is something which new technology is allowed to do and should be performed in every patient. So that's about the screening. What about the treatment? Well, on our part, we should control diabetes as well as we can. We all know it. That's one of the canonical slides from DCCT. Again, type 1 diabetes patients, those who are in intensive therapy group had much lower risk of developing retinopathy. And interestingly enough, in every long-term study, whether in type 1 or type 2 diabetes, in all the studies which aimed at assessing the effect of lowering glucose on macrovascular complications, they sometimes failed, but they always showed the beneficial effect of lowering blood glucose on retinopathy. This is a very hyperglycemia sensitive complication, so whatever we treat, however we low glucose in our patients, lower it, we always saves the eyes. And it also has been very well documented in UK PDS for type 2 diabetes patients, where lowering HbA1c by 0.9% over the course of 10 years since the diabetes diagnosis decreased by over 20% the risk of retinopathy. The actual reduction nowadays could be much bigger, because this study was started in late 70s. Diabetes was diagnosed at much higher levels of glucose. Nowadays we could be even more effective in eliminating retinopathy. If we fail, or the patients fail, or we altogether fail, and the patients do develop any changes in the vasculature in the eye, then it's time for panretinal laser photocoagulation. This treatment looks kind of a brutal one, and it's actually quite primitive in terms of how it is done. But it works very well in prevention of the advancement of retinopathy progression. If you've never really heard or thought about it, the idea of the treatment is to destroy with a laser or peripheral part of retina, but leave the middle part where the macula is intact, and thus to increase the blood supply to the center of the retina, because the blood can no longer reach the peripheral part of retina. So, as I said, it's pretty primitive and brutal as an idea. But when it was introduced, it saves vision in many patients. It does not restore the vision lost, but because the oxygen supply increases hugely here, the retinopathy progression is very effectively halted. It stops. And the patients go usually several courses of laser retinopathy, of laser photocoagulation, and it is okay, they may stay okay for years. So whenever an ophthalmologist says, well, you need a laser treatment, we should always support it. We also should explain to the patient that it might be painful, because it is painful. It's 200, 300 laser shots in the eye, so it might cause pain during the application. It also may lead to bleeding. That's the risk of this treatment, but it is highly effective. But again, it doesn't restore the vision, so the patient shouldn't have unfounded expectations. We should also remember, and we should also tell the patient that it will destroy peripheral photoreceptors, but as it happens, we don't use the peripheral retina very much for our vision. It doesn't restore what was lost. We don't really know what is the exact mechanism. This increase in oxygen supply clearly works, but there might be other issues. Potentially, it might cause bleeding, which is a severe effect, and it is not much useful, and if it is done only in part of retina. It should be done, the proper name is pan-retinal, so it should go all around retina. And if that fails, or the patient has bleeding, or if simply cannot see anymore because of everything what happened in vitreous fluid, vitrectomy is performed. It is still it's a kind of ocular surgery. Not all ophthalmologists do it, of course. That's a major surgery in the eye, and the main indication is the hemorrhage, which left signs, scars, those membranes in vitreous fluid. Also the risk of retinal detachment, especially if it is a traction detachment. That's the clear indication. For macular edema, it is less and less used because we have more effective treatment, which I will show you in a moment. The patients are not happy when they hear, well, we have to make a surgery, we have to remove all the vitreous fluid, we'll put something new into your eye. But once the patients I've seen, they usually see better. It doesn't, again, restore the vision to what was before diabetes, for example, but the vision improves and the patients may remain self-dependent, which is the main worry for most, or if not all, our patients. So macular edema, how can we treat it? That's again an example, the picture of macular edema in OCT, the central part, the cystoid-like form. Then this type of treatment is nowadays more and more often applied. They are intravitreous injections with number of different agents. I'll show you in a moment. So it looks quite brutal as well. There is an injection into the eye. The drug fills the vitreous fluid, and it acts the way that it either stops the new vessels being formed and stops the leakage, and also decreases macular edema. And that's the effect of this treatment, that this is exactly the same retina you've seen a moment ago, and after the treatment it really restored to normal. The rationale for this treatment, because there are two types of drugs which are used, and most often these ones are used, we call them anti-VEGF therapy, the antibodies against vascular endothelial growth factor. The mechanisms for this is again like it follows here. This protein, this growth factor, controls the permeability of retinal endothelial cells, but also stimulates the growth of new vessels. It is increasingly produced the more retina is becoming ischemic, the more VEGF and other compounds, but VEGF is the well-studied and most prominent here, is produced. So the concept was to produce autoantibodies which would block the action of this growth factor. And as it was shown in the studies I'll show in a moment, it clearly works. It also causes the breakdown of the blood retinal barrier because it is supposed, this growth factor, it is supposed to increase, to facilitate the creation of new vessels. So if we block it, then we block the leakage, we block the permeability, and we also inhibit the formation of new vessels. And that's one of the first studies which documented how effective this treatment could be. This is ranibizumab, one of those drugs which are used with laser or without laser, and you can see that addition of laser was giving no benefit. All what was achieved thanks to the use of this drug, and it improved the acuity of vision, to put it in the most general terms. There are several problems here again. One problem is that the injections are performed monthly, and the patient should have at least 3 injections for the treatment to be assessed whether it's effective or not, because it's not effective in all patients. In majority, yes, but there are groups of people who do not respond to this treatment. Ophthalmologists say that the best thing is to get 6 to 8 injections every month. And the problem is the price, because the drugs which are licensed to be used for this, the cost is about 250 euro per 1 injection. So it's a lot of money, and it's not reimbursed in many countries. You can use the drugs bevacizumab, which is registered for oncology indications, for example, and you can also use lower doses, and the cost of the injections might come down to 100 or even 50 euro in some countries, but this is an off-label use, and those companies who produced compounds who are licensed to be used for this treatment are fighting fiercely with these cheaper options. But we still use it because it's more important for the patients to get the treatment than to follow the routine, really, or the procedures. This is the latest study which shows the most. There are 3, I'm not sure if you can read it. One is aflibercept, bevacizumab, and ranibizumab. There are 3 main antibodies used for this treatment. And again, you can see that all 3 improved visual acuity. That's a 1-year observation. But what is interesting here, they are not all effective the same way. The most effective is aflibercept, this green curve. This is the largest, the greatest change seen here. And also, this was a very large study, over 600 patients, in multinational, multi-center, blinded, a very well prepared study. But what they also showed, that the patients who had more advanced macular edema, and these are the patients which on the bottom figures are shown in solid lines, they benefited most. Those dotted lines are the patients with less advanced changes. So there's a good hope for patients even with advanced macular edema. They will still have more effective, they can see more effects treated with this expensive type of treatment, but still recommended. And now it has really become a treatment of choice if diabetic macular edema. The other drugs which are used, if we cannot afford these ones, you can use triamcinolone, which is a powerful steroid hormone, which is also used by ophthalmologists. It's anti-inflammatory. It also stops the blood from leaking. It stabilizes the endothelium. So there are some benefits described with steroids given to vitreous fluid as well. And finally, are there any other options we should consider? There are data about fenofibrate, the drug which is used for hypertriglyceridemia, from the field trial and also from the ACCORD trial, that patients who already had mild background or simple retinopathy, when they were treated with fenofibrate, this slowed the progression of retinopathy. It did not prevent the occurrence of new cases of retinopathy, but slowed the progression. Fenofibrate has not been licensed, registered with this indication but I personally and many of my colleagues also tend to use it in patients with developed retinopathy. And a word of caution with glitazones. There are quite a few reports, and this is a larger study, showing with the patients who are treated with insulin and TZDs, mostly pioglitazone, run the higher risk of developing, this is the curve, the line which shows the incidence of diabetic macular edema until 10%, which was like 4 times more than patients who were not using TZDs. We simply might increase the risk of macular edema development, and there are some cases being described as well. That's one case published over 10 years ago with pioglitazone here. It's this is the edema here, and when they stopped pioglitazone, it disappeared. So the drug should not really be used in patients with any suspicion of macular edema present. So just to summarize, what's our role in prevention and the treatment of diabetic retinopathy? Screening is the most obvious thing. No one will do it but us, and the patient should be aware of its importance. Patients should be referred to ophthalmologists when it is only needed. We should explain all the risks of and benefits of the treatment, especially anti-VEGF therapy. We should use the drugs with known beneficial effect, and I haven't mentioned that, but it's kind of self-evident. Once we have a patient with retinopathy, we also should screen for all the other vascular complications, be it micro or macrovascular, because very rarely retinopathy is just alone complications. We might expect a neuropathy, nephropathy, but also changes in large vessels as well. So to conclude, the retinopathy, as I told you, might be getting slower, but the number of patients will not be decreasing. We see more and more people with diabetes, and they live longer, so they will develop retinopathy for sure. It is still the main cause of vision loss worldwide, as I said, not perhaps in Europe, but worldwide. We should remember about glucose control, which is very obvious, but not only. I showed you UK-PDS results on retinopathy with glucose lowering, but also UK-PDS showed that blood pressure lowering is beneficial for retinopathy prevention. So, but we do it on an everyday basis anyway. Importantly, there are no drugs which are registered, licensed to be used for a diabetic retinopathy. In my country for years, the drug which was very popular, for example, was calcium dobesylate. You might have heard the name. And it really works like placebo in retinopathy. But still, there is such a need from patients that, okay, the doctor, there is something wrong with my eye. I should be taking some pills to help it. And so eventually they end up with some vitamins, but it also works like placebo. But there are no drugs which have been shown to be as a systemic treatment for retinopathy. Screening is mandatory, laser is very effective, as I showed you, and now anti-VEGF therapy is a standard therapy. The main barrier is the cost, and the governments are not very happy to reimburse it, even in well-off countries. And we are kind of responsible for preventing and also the treatment of retinopathy and preserving vision in our patients. We mustn't ever forget about it. Thank you very much for your attention.
Thanks a lot, Dr. Czupryniak, for this wonderful talk with a lot of information and new knowledge. Thank you very much. I have one question for you. The role of a vascular endothelial growth factor in the pathogenesis in nephropathy, is it the same mechanism in retinopathy?
Well, not necessarily, because in retinopathy we have there are other factors present, like albumin crossing base membrane in glomeruli. This is something we don't have in the eye. The kidney is filtrating, there are fluids and everything going through membranes, and it's not the same mechanism. There were other studies, because there there were reports suggesting that using this in patients who used consecutive injections of anti-VEGF compounds, they've been seen to have improvement in nephropathy as well. So what was injected in the eye somehow got to the kidneys and helped. But it is a sort of a chance finding, and it's not an indication. So it's really the topical action of these drugs in the eye. So VEGF is it's much more important in the eyes than in the kidneys.
Another question, please, about is there any evidence between attacks of hypoglycemia and deterioration of retinopathy?
It is emerging now, because now we look at hypoglycemia at as a much more serious problem than we used to. Hypoglycemia in a way causes the same effect what hyperglycemia, but in different mechanism. Because in hypoglycemia, endothelial cells gets less glucose, so they also get less energy, they become less effective, and it also leads to the same, very similar, as we now know, damage to the vessels as hyperglycemia. But we lack proper long-term studies, because for years we were fighting hyperglycemia. Now we can manage to bring glucose as low as it is possible, and now we have increased risk of hypoglycemia, but for decades it wasn't an issue. But if you listen, and you still can listen to the excellent lecture of Professor Brian Freer, if you go to EASD virtual meeting website, he received the Camillo Golgi Award for his lifetime 30 years work on hypoglycemia. He makes a very good case at the end of his talk that hypoglycemia initiates all the mechanisms which are very similar to the ones initiated by hyperglycemia. And even if you argue, okay, but hypoglycemia only lasts for a short moment because then patients save themselves, there is evidence showing that after severe hypoglycemia, all those pro-inflammatory, pro-atherogenic changes are maintained up to 2 weeks. So probably we will end up with the same mechanisms. And just mimicking the nature and replacing the control of glucose level at an ideal way, which happens in physiology, will be still a challenge, because even if we control hyper, we will still fall into the risk of hypoglycemia. Yeah.
And about phenofibrate, is the correlation, was it a proved causal relation between hypertriglyceridemia?
It's now well understood. Phenofibrate is a PPR PPR alpha agonist. And it's well, I have no time to explain it, but it's well documented now, also in experimental work, how stimulating PPR alpha receptors may improve oxygen supply in the retina. So yeah, I'm pretty convinced, and there is evidence that it's not a chance finding. And there are at least 2 studies, Field and Accord, which confirmed it. The problem, the only legal problem, is that Abbott, the company which produces phenofibrate originally, applied for this registration in retinopathy, but still there is no decision, at least from the FDA. We all follow what FDA tells us to do.
Thank you, sir. My name is Leszek, working in Cairo University. What about the data about GLP-1 analogs when they used some change in worsening of retinopathy, like in semaglutide trial, analogotide trial? Do you have any data why GLP-1 analogs can worsen retinopathy?
As far as the question is about semaglutide and the 5 cases of blindness in the study. As far as I know, as of today, the understanding is that semaglutide was too good a drug. It simply lowered blood glucose too quickly, and the situations which was found there, is very similar which we saw in pregnant women with type 1 diabetes who were poorly controlled. They came to a doctor and they said, okay, look, I'm pregnant now, I'm ready to change a lot to get my glucose to proper levels. We lowered blood glucose very quickly, because in pregnancy you have no time, and then they experienced deterioration of retinopathy. And this is somewhat what you asked. It's a sudden drop of glucose, and it's further damage to endothelium. So that's how Novo Nordisk tries to explain it's not the drug itself, it's the potency of the drug in controlling blood glucose. But I guess we need a bit more studies to be fully convinced that GLP-1 agonists are safe here, especially that with liraglutide in LEADER study, there was also a slight tendency to increase retinopathy. So we have to see it. But for me, it sounds plausible. It's just the potency of the drug, not the drug itself. So it probably has to be introduced at lower doses in some cases, or be used in special caution in patients with retinopathy.
How can you manage patients with diabetic retinopathy and at the same time they are in need for antiplatelets for prevention of myocardial infarction or cerebrovascular stroke, and patients also with diabetic retinopathy who are in the stage on regular dialysis and need heparin during dialysis session? How can we manage these cases?
So you ask about antiplatelet therapy in patients?
Or anticoagulant.
Anticoagulant, in general.
Antiplatelet or anticoagulant.
Yeah, anticoagulant therapy, patients who need laser therapy. With antiplatelet therapy, the aspirin, everything was stopped a few days before, but that's probably not necessary because the risk of bleeding here is little. When they take these new anticoagulants agents, they are usually stopped for a couple of days before. But again, there is little data that it's harmful. What is done with laser is just it's really, if you've ever seen it, if you've seen ophthalmologists doing it, it's the tiny shots, but of course it may shot the vessel. So if I have a patient who's on aspirin, I usually say it's really no need to stop it. But if they take new anticoagulants, they stop it for a day or two, no longer. There's no need to go on heparin for this, that's for sure. There was also at the beginning the suspicion that they have to be switched on heparin subcutaneously and then have a major laser, not anymore. But with newer anticoagulants, especially in older patients, probably I go slightly beyond recommendations. I'm quite cautious, but I've seen many old people having severe bleedings after new anticoagulants, and only one of them has antidotum. So it's always it is a challenge. But laser therapy should go first, I believe, because the vision should be safe. Okay, I thought it's a boring lecture. It's what's new about retinopathy.
Is the presence of retinopathy is an absolute contraindication of pregnancy, or depends on the stage of retinopathy?
No, it's not a contraindication to retinopathy, to pregnancy. Absolutely, it only has to be controlled, and the issue is not to change the glucose control too dramatically. But not retinopathy is not a contraindication nowadays. At least in Europe, we do not tell women, okay, you have advanced retinopathy, you shouldn't get pregnant. They should be under more intensive care in a way. What happens in my country, again, we have a very big maternity hospital in center of the country, and they have 2 big wards. They look after women who are pregnant and have diabetes. Sometimes they spend half of their pregnancy in this hospital, but we don't discourage them. If a woman wants to become pregnant, she will become pregnant anyway. So, and we also think we shouldn't deny the sort of a blessing of having a child, especially if you have type 1 diabetes. You need care in your later years, and the children should care after you. So no, it's not a contraindication. Okay, thank you very much. I guess we should rush with
Thank you very much.
Thank you.
And now I have the pleasure to introduce Professor Andrew Boulton. He's the past president of the European Association for the Study of Diabetes. The talk is about diabetic nephropathy, prevention, screening, and treatment.
Thank you very much. As I said yesterday, a pleasure to be here in this beautiful city. And when my slides appear, I will start. Looks like they're about to appear. Okay. This is a brief outline of what I will be saying in the next half hour or so. I don't need to tell you, because I told you yesterday, that the diabetes epidemic is ongoing, the 21st century epidemic, a very serious condition. And I show you this slide, which is from the Diabetes Atlas in 2011, because basically what they projected for 2030, we are there already, if the truth be known. Now, you just heard from Leszek in a very nice talk on diabetic retinopathy, the importance of screening. This slide emphasizes the importance of screening. If you see here on the left that because of our retinal screening program that is the envy of the rest of Europe, I'm told by Leszek, diabetes for the first time in the last few years is no longer the leading cause of blindness in England, because everybody has a letter from their GP once a year or from their optician. We have a retinal screening program where all patients are screened. Anything worrying, and this is read centrally by an expert, so they have a retinal photograph at their local optician, they don't need to go to their GP. This is read centrally, and any worrying features of retinopathy, they get an immediate referral. So this emphasizes the power of screening. In other words, secondary prevention. The patient already has diabetes. The secondary prevention is preventing the development of late complications. And the same is true for the kidney. So now we're going to focus on the kidney. It looks a bit like a boxing glove there, but it isn't. That's the kidney. And the importance of screening here, I cannot overemphasize. The consequences of diabetic nephropathy are horrendous. Now, we know from this study, just published a couple of years ago, that life expectancy is reduced by 12 years in those who have diabetes and cardiovascular disease. That's the bottom here, the bottom diagram there. But it's even worse in diabetic nephropathy. Diabetic nephropathy and mortality in diabetes, this is from the big Finn-Diane study led by our good friend Per Henrik Group, former secretary. He worked with me as program chair when I was president of EASD. And this shows on the right, if you've got end-stage renal disease, you've got a huge increased risk of mortality. And this has been known for many years. Here are data from the Pima Indians in Arizona, and there, those with proteinuria and diabetes, again, a huge increase in type 2 diabetes in mortality. So chronic kidney disease is the major predictor of mortality in type 2 diabetes. And this study, published 10 years or so ago from Italy, shows the impact of macroalbuminuria on the right hand there, and if your GFR is less than 30, look at the huge increase hazard ratio there. Here again is a study from the South Tees study, that's in Northeast United Kingdom. And this shows the impact of following 10 years of patients, again with eGFR of less than 30, you see the impact there on death, mortality. We know that end-stage renal disease incidence have been rising. They are curving off now in some countries, especially in type 1 diabetes, but because of type 2 diabetes, many patients are not diagnosed for the first 10 years, and they've already got renal disease when they're diagnosed, so it's not going to fall in type 2 diabetes for a little while. And here are the end-stage renal diseases due to diabetes in the United States until the year 2007. When I go to the dialysis unit in my hospital, I know half the patients there because diabetes is the commonest cause of patients ending up on dialysis. And I set up a combined diabetes renal clinic with nephrologists some 30 years ago in Manchester. We now have the largest combined diabetes renal clinic in the UK. So the combination, cardiovascular risk is greatest when you've got diabetes and chronic kidney disease, and the study from Foley from Canada suggests this here you see. So there's an added burden of chronic kidney disease on top of all the other problems of diabetes. You remember the Greek mythology, Sisyphus was a king who was punished by being compelled to roll this immense rock boulder up a hill only to watch it fall back again, and he had to do this for eternity. This is the addition of chronic kidney disease to the other problems of diabetes. So what is the face of diabetic nephropathy, and how do we diagnose and classify it? Well, of course, as I said yesterday, we can envisage the retina non-invasively, as you just heard from Leszek. We can look at the kidney non-invasively because urine is the mirror of the kidney. And as I discussed yesterday, until we developed the corneal confocal microscopy, we could not see peripheral nerve in vivo. So normal albuminuria is defined as an albumin excretion rate of less than 20 micrograms per minute or less than 30 milligrams for 24 hours, or an albumin-creatinine ratio on the first morning sample. Microalbuminuria is a slight increase in this, defined there, and I'm sure you all know this, and macroalbuminuria is when you're dipstick positive. In other words, the albumin excretion rate is greater than 200 micrograms per minute or 300 milligrams per 24 hours. What about type 2 diabetes? Is microalbuminuria always diagnostic of kidney disease? Probably it may not be. This is work from our vice president of EASD, Paolo Fioretto, when she was working in the United States some 20 years ago or so. If you look at kidney biopsies, by the way, I would not advocate doing kidney biopsies, and we can discuss this at the end if you want. We rarely do kidney biopsies, but this was a study some years ago. Microalbuminuria in type 2 diabetes, unlike type 1 diabetes, where microalbuminuria is invariably due to diabetic nephropathy and the patients invariably have retinopathy as well, not so the case in type 2 diabetes. 30% may have near normal histology on a kidney biopsy. Only 30% will have typical diabetic nephropathy. And in type 2 diabetes, renovascular disease is common as well. And retinopathy may not always be present, and there are a number of reports to suggest that this is the case. And non-specific findings are often found as well. This is an old study looking at progression of diabetic nephropathy. If you've got proteinuria of more than 500 milligrams per day, you get progression of disease in terms of reduction of GFR. This is no longer the case with good intervention. Here's a nice study just published more recently, again from the FIN-DIAN study, looking at the impact of glycated hemoglobin and the standard deviation, in other words, glucose fluctuation. And at the bottom here, you see the most likely to progress are those who as mean is above the mean glycated hemoglobin, in other words, you've got poor control, and it's variable, the standard deviation is above, and that's most predictive. So glycemic control does matter. And we know that intensive glucose control also reduces the risk of development of macroalbuminuria, and this summary and systematic review looking at a number of more recent trials and some of the older ones showing that intensive glucose control does also reduce not only the risk of microalbuminuria but of macroalbuminuria. So the natural history of diabetic nephropathy in type 2 diabetes, one sees functional changes, structural changes in some, rising blood pressure, microalbuminuria progressing to macroalbuminuria, rising creatinine levels, and end-stage renal disease. This is a natural history of untreated diabetic nephropathy. Now, today we widely use formulae to estimate the GFR. The original Cockcroft-Gault was 40 years ago now, and now we much more commonly use the eGFR, or creatinine clearance, which is adjusted. So there are a number of different formulae, but all of you, I'm sure, are now talking about the estimated GFR, which, how it is calculated, I will not read that out because it'll use up too much time. But that's the eGFR that is a good measure of kidney function. But please remember, the eGFR, like the blood glucose, is variable. I get letters from primary care saying, urgently see this patient because his eGFR was 80 and now it's 75. But you know, the next week it's probably going to be 80 again. So you need to look at the trend, not one or two readings. How do we define chronic kidney disease? Well, these are the stages of renal function as follows. And the ones that we generally worry about are stage 3, which is eGFR of 30 to 60 mils per minute, stage 4, which is pre-end-stage renal disease, 15 to 30, and less than 15 is defined as end-stage renal disease. But I would urge caution again, that these are variable and never look at just one reading, look at a trend. And I think that we label too many people as having chronic kidney disease when they may well have normal function. And I'm especially referring here to the older population. Do up to 50% of the elderly population have chronic kidney disease if we go by these definitions? I would suggest that they certainly do not. Here was a nice study a couple of years ago looking at chronic kidney disease in the elderly. Is it disease or is it a disease label, because we're using the EGFRs that are for the average middle-aged adult and not for the elderly? Remember that above 50% of patients over 75 will be defined as having stage 3 renal failure. Remember that in healthy patients, the GFR, renal function, gradually declines with age. And I think that the risk of end-stage renal disease is minimal in older patients with EGFRs in the stage 3 range, especially those 45 to 60. Epidemiological risk stratification is not suitable for that population, and I think you need to individualize. So I saw a patient in my renal clinic just before I came here on Wednesday. I was in my clinic. You know, a patient of 75, their EGFR is 46. I said, you don't need to worry. This is probably normal for your age. And I don't think you've got chronic kidney disease. And I suspect I'll be correct, but I can't prove that yet. So what is the prevalence of chronic kidney disease in patients with diabetes? And here's a nice study from Australia some 10 years ago, just looking at a large number of patients, nearly 4,000 patients with type 2 diabetes. Around 53% of patients had normal renal function, and you see the percentages here with micro, macro albuminuria, and what we would define as stage 3 kidney disease. What are the implications for clinical practice? Well, with declining renal function, please remember that many of the drugs we use, and we use many drugs, often I feel too many drugs in people with diabetes, many of these are primarily eliminated by the kidney. So one needs to look at all the medication load of our patients who have stage 3 or lower chronic kidney disease. Declining renal function decreases clearance rates and increases exposures and increases the risk of side effects. Several of our anti-diabetes medications should be avoided or used with caution in those with declining renal function. And remember that declining renal function increases the risk of severe hypoglycemia. And you see the bar on the left. This is the risk for severe hypoglycemia. If you've got chronic kidney disease and diabetes, there's a huge increased risk. Here are patients with diabetes without chronic kidney disease, and so on. So this is well recognized. Sulfonylureas cause hypoglycemia, and they're more likely to in patients with chronic kidney disease. So we need to balance the desire to lower blood glucose against the risk of hypos. And if you think about it, if you've got a patient who's already got, say, an EGFR of 30, they've got diabetic retinopathy, they're almost certainly going to have diabetic neuropathy, and they've got diabetic kidney disease, what is the advantage of driving the glycemic control very low? Probably very little. They're probably going to have loss of hypoglycemic awareness with long-standing type 1 diabetes, and the risk of hypoglycemia is much greater than the benefit that might be achieved, and that is dubious, by having tight control at that stage. And we need to remember that. So the risk factors for hypoglycemia include all of these factors: age, gender, body weight, duration of diabetes, previous hypoglycemia, but renal dysfunction. Why are more hypos, and why are they worse in people with with chronic kidney disease? Insulin half-life is prolonged in established renal failure. And don't forget, 20% of gluconeogenesis comes from the renal cortex, so you've got less glucose stores, impaired glucagon, impaired sensing, and so on. So don't drive the blood glucose too low in patients with chronic kidney disease. And here are some recommendations that many drugs should be avoided, and I think sulfonylureas should be avoided in patients with chronic kidney disease because of the risk of hypoglycemia. Biguanides I'll come back to because this has changed in recent years. DPP-4 inhibitors, some can't be used, but remember that you can use linagliptin. Linagliptin is entirely excreted in the biliary system, and the risk of hypoglycemia is very little in these drugs anyway, but it's absent in those with linagliptin and chronic kidney disease. So you can use that one safely. Here are some data from Australia that despite the advice, sulfonylureas are being used really very commonly in patients who have established chronic renal failure, and I would suggest that this is inappropriate. Metformin use as well. Okay, it's being reduced in those with less than 30 GFR. But what about metformin? Can it be used safely in patients with chronic disease, kidney disease? This came up in discussion yesterday on one of my talks. And these are data from my good friend George Bakris, who's a true Greek origin character and a hypertension expert from Chicago, and Mark Molich. And this paper, just published last year, suggests that lactic acidosis is extremely rare, even in the elderly. Metformin can safely be used down to an eGFR of 30, and even the FDA have revised their restrictions, suggesting that this is indeed the case. In those with an eGFR of 30 to 60, perhaps some care with dosages, especially of other comorbidities, but you can use metformin safely in this group. I think its usage remains contraindicated in those with an eGFR in stage 4 or 5, less than 30, but I have to say that the evidence to support this statement is pretty weak. Pretty weak. This is mainly from expert opinion, which, as you well know, can often be wrong. So how do we approach diabetic nephropathy? What's your task as a doctor in the treatment of those with diabetic kidney disease? Now, untreated, this is a natural history, as I showed you earlier. And what we would love to do is to be able to reverse it, or at least stop further deterioration. And I have to say, it's been a pleasure looking after many patients in my diabetes renal clinic I've known for 30 years, and with aggressive control of blood glucose early on, but more importantly, aggressive control of hypertension. I still have patients now who have come to this stage here, and we've been able not to reverse, but to hold them, keep them away from dialysis. Life on dialysis, as I will show you, is no fun. It's a miserable existence. I would say that dialysis only keeps you alive while you wait for your transplant. That's what I would say. What about blood glucose control? I've suggested earlier that this may be important. And we know from the DCCT and the EDIC study that the fact that you've got better control, but despite the fact that control merged together during the epidemiology of diabetes and its complications study, and I'm privy to a lot of these data because I sat on their advisory committee and representing neuropathy, and it was very interesting to see the legacy effect. So intensive glycemic control continues to prevent albuminuria even during the follow-up study. After 10 years of tight control, when control weakened or worsened, there was still this legacy effect. And the same was seen in our UK PDS in type 2 diabetes. Same. Here is the legacy effect here, again, after the UK PDS. Median follow-up, you can see in any diabetes-related endpoint and microvascular disease and others, you still have this benefit of a period of better control than the other group. Now, smoking. I must say, I'm surprised to come to here and find people smoking inside a hotel, and to find doctors smoking, which is worrying. And in Europe and North America, you cannot smoke anywhere. In America, you can't smoke within 50 feet of any airport door, so you have to stand in the highway, which would probably get killed by a car before lung cancer. But smoking is bad. And here are data from the FINDIAN study showing the effect of smoking on top of other features. And you see here in these lines, smoking leads to increased development of nephropathy. So the speed of kidney deterioration depends how many cigarettes you smoke a day. Best to smoke none. Blood pressure lowering, the most important fact. One of the most difficult things, I see patients who have had type 1 diabetes for 20, 30 years coming to my renal clinic, and I say, look, you really need to focus on blood pressure. It's more important than blood glucose, and that's sacrilegious to them. They've been hammered for years, you've got to keep your blood glucose good. But blood pressure is more important. And what I encourage, and most of my patients in the diabetes renal clinic not only do blood glucose monitoring, they do blood pressure monitoring at home. And I would advocate the purchase of one of those small mobile blood pressure monitors that the patient can use at home. You see, the hypertension people are years behind us in diabetes, which is how I usually tease them. You see, we have glycated hemoglobin. They haven't got a glycated hemoglobin, which gives us 3 months of average control. So the hypertension people haven't got that. When my first diabetic clinic was 40 years ago this year, and people would come in and have a random blood glucose done, and I'd say, oh, it's 6 or 120 milligrams percent. Right, well done, we'll see you in 6 months. We would never do that today. We have self-blood glucose monitoring, continuous glucose monitoring, we have blood pressure, glycated hemoglobin. But if you look at hypertension, they still do a random blood pressure in the clinic and increase the tablets on one reading, as we did 40 years ago. Their only measure, glycated hemoglobin, is heart attack, stroke, etc. So we're ahead of them. So we can do blood pressure monitoring, which is what I encourage, just like patients do blood glucose monitoring at home. The classic paper from Hans-Henrik Parving, who we recently made an honorary member of EASD, his wonderful studies in diabetic nephropathy over 40 years. This is the classic study of deteriorating renal function in terms of rising creatinine and albumin excretion and reducing GFR associated with high blood pressure. Intervene even late on and you reduce the rate of decline. Many other studies have shown this, and we use ACE inhibitors, angiotensin receptors blockers, and here is a study, there's a lot of studies over the years, captopril, reduced risk of developing diabetic nephropathy. ACE inhibition, again, microalbuminuria, the Benedict study. These are old studies, but they've shown that really, this is verapamil actually, and there is, versus trandelapril, a benefit there in both irbesartan and A2 receptor blocker. All these studies show benefit. Losartan here in type 2 diabetes, preventing progression to end-stage renal disease in the Rationale study. And these are classic studies, but they have informed our management of diabetic nephropathy over the years. Multifactorial treatment in type 2 diabetes, of course, came from the famous STAIN-02 study. This was the first paper, and there's been a subsequent paper led by Olaf Pedersen, a wonderful diabetologist again in Copenhagen, who we've recently made an honorary member of EASD. And this is targeted, intensified multifactorial intervention, the primary composite endpoint at tackling lifestyle, blood glucose, lipids, blood pressure, etc. And this shows how we should treat. We should try and get optimal blood glucose control to prevent diabetic nephropathy in type 1 and type 2 diabetes in the patient who doesn't have diabetic nephropathy. Stop smoking. Blood pressure. In microalbuminuria, I don't aim for the normal blood pressure. I aim for age-matched normal. So in a young person with microalbuminuria, we're looking at blood pressures going to about 120/75. It should be age-matched normal, lowering of blood pressure. And the proteinuric blood pressure should be even lower for those with proteinuria. ACE inhibitors and AR blockers, and of course lipid-lowering treatment as well. These are all important. Now, some patients will develop end-stage renal disease. And I have to say that we now have a conservative clinic, and that's not a conservative party clinic, a conservative clinic where older patients with EGFRs of 10 to 20 who don't want dialysis. They've been to look what it's like. They've talked to patients on dialysis. And with dietary modification, blood pressure control, we can hold people at that level without uremic symptoms for years. And I think that's a big step forward. Because as I said, dialysis is miserable. Of course, the treatment options, number one treatment option is to prevent the end-stage renal disease by the interventions I've suggested. If you're there, then the renal transplant is the treatment of choice, and dialysis keeps you alive while you're waiting for that. And we use peritoneal dialysis, and we have a big unit for PD. We've got many patients on peritoneal dialysis. We use APD now, automated peritoneal dialysis, which is overnight. Some patients are still on continuous ambulatory peritoneal dialysis. Of course, the risk of infection and peritonitis is always there. We have home hemodialysis. We have some patients on home hemodialysis, but most patients have dialysis 3 times a week for about 6 hours, each of those 3 visits at the hospital dialysis unit. I would really advise you to look at this nice paper in the British Medical Journal in 2012. This is patients writing about what it's like to be on hemodialysis. This patient here, Mr. Evans, said being on dialysis isn't really a life, it's not even half a life. And this lady, a non-diabetic lady, she said dialysis is brilliant, of course, but deeply horrendous. And then, this is a non-diabetic lady watching other patients on the unit. On the dialysis unit, patients suddenly appear with amputations. But before that, they have heavily bandaged feet, rapidly followed by crutches, and then wheelchairs. This is the observation of someone with glomerulonephritis, looking at people with diabetes coming on, and that leads you into our work about the strong link between risk of mortality and risk of foot problems in those on dialysis. This is a series of papers we published a few years ago looking at foot problems in patients with end-stage renal disease on dialysis. We showed that dialysis is an independent risk factor for foot ulceration. And if you look at patients with end-stage renal disease not yet on dialysis, their risk of a foot ulceration is much less. Those on dialysis with a similar GFR compared with those not yet on dialysis have a 4-fold increased risk of foot ulceration. Mortality after amputation is extremely high, and we believe that there is a need for foot care on dialysis units. We see heel ulcers develop. Patients just sit with their heels for 6 hours, 3 times a week, and they end up with a heel ulcer. Because they're overwhelmed by the miserable feeling of being on dialysis, they forget about the feet because they don't hurt, because they have lost the gift of pain. These data are very worrying. This is mortality dialysis and foot ulceration of 192 patients we followed for 2 years. The 2-year mortality was half. Half of these are dead in 2 years. But if you've got an amputation and you're on dialysis, 3 out of 4 are dead in 2 years, 74%. These data are worse, as I said yesterday, than almost every form of cancer. So we've got to take diabetes seriously. And remember, if you're on dialysis, you don't need to examine the feet to see if they're at risk. They are at risk. You need to examine the feet to prevent problems developing. And they need to have education and so on. So we have renal replacement therapy. The best is transplantation. I've got some patients now 30 years after a transplant with normal renal function. In my combined diabetes renal clinic on Wednesday, I saw 3 patients in one morning who had simultaneous pancreas kidney transplants, doing very well with normal renal function and normal blood glucose control after this combined transplantation. That's not the preferred treatment, though. The preferred treatment is to prevent diabetic nephropathy from developing at all. So the take-home messages you already know about diabetes is increasing. Here, that's certainly true. Diabetic nephropathy is common. The consequences are grim if left untreated. Screen for diabetic retinopathy, of course, and for diabetic nephropathy. They tend to go together. And both can be treated and prevent progression by early screening. If you get patients with microalbuminuria, hammer the blood pressure down to normal, the chances of them progressing are markedly reduced. So it's early and aggressive multifactorial treatment. And remember, microalbuminuria is not just a test result you file in the notes. It's a call for action, intervention, and prevent progression to something which is miserable. So here's a quotation. Some people make things happen. Some people watch things happen. Some people wonder what has happened. Let's go to the top and make things happen, because we can reduce the incidence of this terrible complication by early screening and intervention. Shukran.
Thank you, Professor Andrew, for this useful and practical lecture. And if there is any question or comment, please, Doctor. Okay.
Thank you, Professor Andrew, for your elegant lecture. I want to ask about if a patient with type 1 diabetes developed micro or macroalbuminuria, what is the action? What is the action I must do?
What is the action?
Yes.
What do you mean by the action? What should we do?
Yes.
Oh, what should we do? Right, okay. If you've got someone with type 1 diabetes develops macular albuminuria, the studies from Denmark and from guys in London in the 1980s show at this stage you may be able to reverse it. So at the stage of microalbuminuria, there's no doubt in type 1 diabetes that glycemic control is extremely important. So we should be aiming for near normoglycemia, gradually achieving it, never make sudden changes. And these days in our type 1 diabetic patients, for such a patient as that, they would have reimbursed continuous glucose monitoring. So this is very helpful. So we can go for good glycemic control. Again, any elevation of the cholesterol, I think all these patients should probably be on a statin. And thirdly, even if they've got normal blood pressure, I would put them on a low dose of an ACE inhibitor, because we know that ACE inhibitors can reverse macroalbuminuria. So although I cannot prove that all three together works, as they have proven from the Steno in type 2, I think this would be my approach at that stage in type 1 diabetes. All three.
If the patient is normotensive, just microalbuminuria,
I think that
should I begin?
I think
with
some of
ACE?
my colleagues, and probably I as well, would put the patient on a low dose, perhaps enalapril 2.5 milligrams a day, because the evidence is strong for reduction of microalbuminuria with ACE inhibitors.
Yes. What about statin? What is
Statin,
the
again,
problem?
if there's any suggestion, and I think most patients at this stage with type 1 diabetes are going to have a slightly borderline cholesterol, and I think a low dose statin is indicated.
At which age? The same
Well, I only see
begin
adult
with
patients, so I don't mind what the age is. If the cholesterol's high, I put them on a statin. I can't say about teenagers and children because I'm not I'm an adult physician.
Usually begin it after the 12 years old. I talk about younger than 12 years old. It is
Younger than 12 years old, I wouldn't like to comment because it's extremely unusual to see macroalbuminuria in that group. And I think one would be much more careful in that age group with a statin, certainly.
My question about, about SGLT2. You know that after the development of these new drugs, they are focused in sodium reabsorption and increased intraglomerular pressure.
Which one? SGLT2s?
Just, yeah.
Yeah, I think SGLT2s will not work in patients with established renal failure, so we don't use them. But I think earlier on, I have no objection to their use because they help with weight loss and they help with high treatment of blood pressure as well. And I think even though there are very few studies in nephropathy, there are one or two that suggest benefit. So early on, but if you've got established renal failure, they're not going to work. I think this gentleman had it, yeah.
Thank you for the lecture. Would you comment on the addition of vitamin D? Vitamin D.
Vitamin D?
In addition to ACE or ARBs?
I think that vitamin D deficiency is common,
some studies show that,
especially in Manchester where we don't have such good weather as here. So I think that vitamin D should be corrected if there is a deficit. But then, of course, in end-stage renal disease, we get into a very complex area with primary, secondary hyperparathyroidism and so on, while calcium metabolism is affected and phosphate, high phosphate, we use phosphate binders. But that's a different, I don't think you're asking about that. I think you're asking about earlier on.
About diabetic nephropathy with normal kidney function. Just
normal kidney function, yeah. We should, we do. We give many patients vitamin D supplements.
Will decrease the proteinuria.
Yeah, we give many patients vitamin D, yeah.
Separate studies.
But later on, I think we've got to be very careful because of metabolic bone disease, we've got to be very careful what we use.
Yeah. Second comment about addition of renin inhibitors or endothelin antagonists. Endothelin. And renin.
Okay, if you're asking about the
proteinuria.
We used to use a combination of ACE inhibitors and ARBs, but recent data suggests that that may not be such a good thing, so we rarely use those together. I've got hardly anybody.
No, this is other than that. A contraindication of giving ACE inhibitors and angiotensin receptor antagonists.
Okay,
but
well, contraindication.
Other inhibitors.
Yeah, I think that I have to say, having done a renal clinic for 30 years, I used to worry about a potassium of 5.5 to 6, but I don't worry about that too much these days. The laboratory will ring and panic. This patient's potassium is 6.2. So we've got to be careful with potassium. And in some patients, in type 2 diabetes, especially if there's peripheral vascular disease, there could be renal artery That wasn't me, no. There could be renal artery stenosis, and in which case you should not use those drugs because it drops intraglomerular pressure, and that would be dangerous. So you've got to be very careful in some patients who are vascular paths, as we say, with multiple vascular disease, about using those drugs because of the risks there.
I'd like to ask about the lowest level of blood pressure, because there is a J-shaped curve between blood pressure control and progression of renal disease. What is the suggested lowest level to bring blood pressure down to?
I think what we aim for, especially in type 1 patients, type 1, because of course the further north you are in Europe, the more type 1 patients you have, so we have a large population of type 1 patients in my diabetes renal clinic. We aim for age-matched normal, so it depends on the age group, the age-matched normal. I think there are dangers in older type 2 patients to drive the blood pressure too low. And has to think about individualization. If you've got someone who's 75 living alone, then the dangers of dropping the blood pressure and postural hypertension, a fall at home, a fracture, then that's it. So I think you need to take into account the age and the type of diabetes.
I'd like to ask about organ transplantation associated diabetes, especially after renal transplantation. If there is any guidelines regarding adjustment, immunosuppressive doses, if the patient developed diabetes?
I'm sorry, I couldn't get. You're asking about post-renal transplant?
Organ transplanted associated diabetes. If the patient developed diabetes.
Secondary diabetes. Oh, okay. Yeah, I saw in my clinic on Wednesday, I saw 2 cases of secondary diabetes, and we know that the calcineurin inhibitors, that anti-rejection drugs, can bring on diabetes themselves, but I would much rather have secondary diabetes and normal renal function. So we know that, NODAT, new onset diabetes after transplantation. There was a symposium on that some years ago at the ADA, a very good one. And these patients have insulin resistance, and they need to be treated because I have to say, and I didn't say before, so thank you for bringing it up, after you've had a renal transplant, glycemic control becomes very important again because of the danger of developing transplant diabetic nephropathy, which we see. So glycemic control is important, and we see a number of patients who get secondary new onset diabetes after transplantation, and we treat them as we'd treat any other type 2 diabetic patient. And these need to be going for near normoglycemia to prevent transplant nephropathy. We use any of the agents, we use insulin, whatever's needed.
What about the immunosuppressive after?
Oh, immunosuppressives, well, we don't meddle with that. The immunosuppressives are essential. And some patients still have steroids if they've had a rejection episode, and I have patients, for example, on mofetil, whatever it's called, mycophenolate mofetil, MMF, tacrolimus, and prednisolone. Okay, they get secondary diabetes, but their kidney function's normal. It's better to treat the diabetes than to fiddle around with the anti-immunosuppressives and lose the kidney.
I want to ask, is there any preference to ARBs over ACE inhibitors in diabetic nephropathy? And is there any preference of a special drug?
I think that now almost all of the drugs have been studied. And if you look at all the trials, we've got captopril, enalapril, lisinopril, losartan, irbesartan, they've all been studied and they all are effective. So I can't say because this patient's type 1 with this level of albuminuria, I'm going to give him perindopril or lisinopril. I think that you'd use the one you're familiar with and it works and it has least side effects. We do get cough in a number of patients on ACE, so we put them into ARBs such as candesartan or something like that. But they're all pretty effective.
Yes. Another debatable issue, kidney biopsy in...
yes, thank you, yeah. Kidney biopsy. I would say that I hardly ever do a kidney biopsy in the diabetes renal clinic. If someone comes to me, number 1, type 1 diabetes, they've got retinopathy, they've got proteinuria, we do a renal ultrasound, we perhaps do some immunology, and the ultrasound's normal, immunology is negative, no indication for a biopsy. That's going to be diabetic nephropathy. Every biopsy has a risk, and there are risks. It's quite invasive, there are risks of bleeding, and so on. Type 2 diabetes, if the patient's got renovascular disease, again, we would not normally do a biopsy. They usually have some proteinuria, again, ultrasound, immunology. Now, I have picked up a couple of abnormal ones. We had one lady who came in And if there's ever any hematuria or even microscopic hematuria, look for another cause. We've had 2 hypernephromas turn up in the diabetes renal clinic, had proteinuria, but also hematuria. That was picked up on an ultrasound, then arteriogram. So they were removed and they're still fine. Again, atypical diabetic nephropathy, that is, if there's little proteinuria, rapid progression, atypical renal size on the ultrasound, then I have a nephrologist we sit together in the clinic, and then we would consider a biopsy. But I would suggest, we've got hundreds of patients, so we've done no more than 10 or 20 biopsies over the last 15 years, I would say.
We see many diabetic patients who develop rising creatinine without the presence of the proteinuria. Is this an indication? This is not the usual course.
If there are atypical features, then one would consider carefully a biopsy after other less invasive investigations, including a renal ultrasound is very helpful. We rarely do an intravenous IVU or IVP, whatever you call it.
Thank you.
Thank you for your elegant lecture. I ask when you are defining stages of CKD, stage 2, certain GFR, and persistence of proteinuria. If proteinuria is improving, what's the stage next? The GFR is the same, but proteinuria improving.
Okay,
What can it
yeah.
do?
I mean, proteinuria doesn't always follow progression. And proteinuria may be high, and we still see, although I must say I see much less nephrotic syndrome than we used to, probably because of good control and good blood pressure control. We still see nephrotic range proteinuria occasionally, especially in type 1 diabetes. I think the GFR, we say stage 2, but stage 2 is basically normal. And I think there are dangers of saying you've got stage 2 and not stage 1, because the patient may be labeled as having some renal disease when in fact they have not. And I think we look at the combination of the two and how they vary. So if you've got someone with proteinuria and it's say 2 grams for 24 hours, we put on an ACE inhibitor to tighten the glycemic control, that reduces to microalbuminuria, then we're quite happy. And we treat the blood pressure, we treat the blood sugar, and hopefully the GFR will not go down. But you know, to say this patient, oh my God, they've gone from stage 2 to stage 3 because they've gone from 61 to 59 is nonsense. And I think it's a variable and it's going to go up and down, and watch the trend and don't just look at 1 or 2 readings. And that's true for most of medicine. It's common sense approach.
Thank you very much, Professor Boulton, for this very informative presentation. Now it's my pleasure to present Professor Evgenya Patrakeeva, consultant endocrinologist at the First St. Petersburg Medical University, especially interested in insulin treatment, patient education, and her presentation is entitled Diabetic Neuropathy, Different Treatment Modalities. Please.
Dear colleagues, dear friends, it's a great pleasure for me to be here in this beautiful country full of history and culture. I work in St. Petersburg, which is also a very beautiful city, as you can see here. But my city is like a baby in terms of age compared to Cairo, of course. And before we start to discuss diabetic neuropathy with different treatment modalities, I want to suggest 2 organizational issues. First one, don't waste your time making picture, because if you need something, some slides, presentations, pictures, guidelines, you can just write me by email, and address is written here. So don't be hesitate or shy, just write me, I will send you everything, whatever you want. And the second issue is about the time. We are a little bit out of our timetable, so I just want to ask you, please ask your questions during the break, or during the lunch, or during the workshop, not after the lecture. Is it okay for you? Yes? Thank you for understanding. So let's start from some main thoughts about early recognition and appropriate management of diabetic neuropathy, which is matter. First is a diagnosis of exclusion. Second, up to 50% of our patients with diabetic neuropathy may be asymptomatic. and it's very important. Third, numerous treatment options exist for symptomatic diabetic neuropathy. And the last one, recognition and treatment of the autonomic neuropathy may improve symptom, reduce sequelae, and improve quality of life for our patients. As an introduction, we have some important fact about neuropathy. Of course, the presence of this complication, even with trivial trauma, is an initiation factor for the development of foot ulceration. The risk for diabetic foot ulceration increases by 7-fold in patients with neuropathy. From 45 to 60% of all ulceration in patients with diabetes are mainly due to neuropathy. And the last one, almost half of the ulcers are due to combined neuropathic and ischemic factors. That's why we need to remember that diabetic neuropathies are the most prevalent chronic complication of diabetes, and it's not only the one condition, it's a group of conditions. Because of that, we need to remember that there are a classification with a lot of forms of neuropathy, with diffuse neuropathy, mononeuropathy, and even radiculopathy, of course, which is atypical. But also we need to remember that there are a lot of comorbidities which we need to differentiate from neuropathy. It's metabolic disease, systemic disease, infectious, hereditary, industrial agents, inflammatory disease, and some nutritional things. That's why just come back to our main thoughts, which was written on the first slide. Diabetic neuropathy is a diagnosis of exclusion. Of course, non-diabetic neuropathies are common in diabetes. That's why non-diabetic neuropathies may be present in patients with diabetes and may be treatable, and we need to remember about it. There are some common facts about pathogenesis which we need to remember. Everything starts with hyperglycemia, with some changes, which leads to nerve dysfunction and death of cells. From the other point of view, if you want to compare a situation with type 1 diabetes and type 2 diabetes, or even both of types, there are some differences between, but the consequences is following. We have DNA damage, ER stress, mitochondrial dysfunction, cellular injury, and irreversible damage. Why is necessary to remember? Because of this complicated pathogenesis, we have a lot of signs and symptoms, even negative or positive, with some spontaneous sensation or pain, or even evoked pain. Also, we need to remember that symptoms don't match signs of nerve damage, and it's very important. Neuropathic pain, it's not an easy condition and occurs in even 30% of patients. We can divide it to small fiber neuropathic pain, large fiber neuropathic pain, and it occurs in patients with long-standing poor diabetes control and increased variability of blood glucose level. Of course, we have a lot of things to diagnose neuropathy, and everybody knows it. And also we need to remember about some possibilities to measure function, pressure, and balance. And also we need to remember about the role of neuropathy in diabetic foot ulcer pathogenesis, as you can see here. If you can imagine the way to the diabetic foot ulcer as a final destination, of course, the first station will be neuropathy. After that may be ischemia, loss of protective sensation, and high pressure points. If we will again describe the pathway to amputation in diabetes in some allegorical way, first stage will be normal foot with absence of neuropathy, and the stage 2 will be high risk of foot, presence of neuropathy. Let's go to cornerstones for prevention of amputation in diabetes, because it's matter. It's periodic foot examination, of course, education not only the patients but healthcare providers, appropriate footwear, treatment of pre-ulcerative conditions, and early treatment of foot ulcers. That's why it's important to remember that if diabetic peripheral neuropathy is not recognized and if preventable food care is not implemented, patients are at high risk for injuries to their insensate food. That's why we need multidisciplinary food care service, which need to include diabetology, nutritionists, podiatry, vascular surgery, microbiology, and some other specialists, and even nurses who are specialized in diabetes. Is amputation really preventable? How do you think? Let's raise your hand who think if yes, it's preventable. Who think that it's not preventable? Do we have some doctors? No, great, because really at least half of all diabetes-related amputation can be prevented by adhering to the good food care and multidisciplinary approach, and it's very important. So what do we need to do for screening and diagnosis? All patients with type 1 and type 2 need to be screened. We need to screen even patients with pre-diabetes. We need to have a careful history examinations and all procedures which we'll describe before. But we need to remember that electrophysiological testing or referral to neurologists is rarely needed. So we can do almost everything by ourselves. Let's start to talk about management of symptomatic diabetic neuropathy and some treatment modalities. Of course, again, we need to exclude non-diabetic causes, including malignant, toxic, iatrogenic. We need to assess level and stability of glycemic control, and we need to explain, support, and educate our patients. If we will divide all treatment modalities to some ways, first of this way is disease-modifying treatment with stable near-normal glycemia and maybe alpha-lipoic acid. And the second part is symptom-modifying drugs, which could be medical and physical. Of course, there are numerous treatment options that exist for symptomatic diabetic neuropathy. You need to remember about it. What do we think about when I'm talking about symptom-modifying treatment? We have antidepressants, anticonvulsants, with some group of medications here and here, and also some others modalities like opioids, others local treatment, and not pharmacological treatment at all. If we will discuss some groups, because it's like a very practical question, and yesterday and tomorrow morning you asked me to be more practical, so I'm trying to do with practical issues. We need to remember not about only about mode of action, cautions, but also about side effects. And we need to remember about sedation in terms of DCA. You need to remember about some problems with nausea when you're working with SNRI, about sedation with gabapentin, something else with pregabalin, and some problems with abuse in terms of opioids. What is the other important question? It's a question about dosage, and the dosage can be different from the initiation and during the treatment. You can see it here when we're talking about the first group of drugs, or here. If you're talking about antidepressants, you also need to remember about the dosage, or even in terms of opioids. So what is the main consideration about pain management? First, we need to consider either pregabalin or duloxetine as the initial approach in the symptomatic treatment. Second, gabapentin may also be used as an effective initial approach. Tricyclic antidepressants are also effective, but we have a high risk of serious side effects. And of course, given the high risk of addiction and other complications, the use of opioid is not recommended as a first or second line agent. That's why we need to remember that, of course, there are a lot of treatment options, but we need to be careful with usage of all these treatment modalities. If you will summarize the process of management, here, tight glucose control in patients with type 1 diabetic dramatically reduced the incidence of distal symmetric polyneuropathy. In patients with type 1 diabetes, with more advanced disease and multiple risk factors and comorbidities, intensive glucose control alone is modestly effective in preventing distal polyneuropathy, and patient-centered goals should be targeted. Lifestyle intervention are recommended for distal symmetric polyneuropathy prevention in patients with pre-diabetes, metabolic syndrome, and type 2 diabetes. And of course, a lot of treatment options we have now. Some word about diabetic autonomic neuropathy. It's a chronic complications. Among the least recognized and understood complication of diabetes, despite its significant. And of course, it's have a good damage for our patient. Is it recognizable? Yes. Is it common? Yes. We have some problems still in screening and diagnosis, but we need to keep in mind that symptoms and signs should be assessed in patients with microvascular and neuropathic complications. In the presence of symptoms of cardiovascular autonomic neuropathy, tests excluding other comorbidities or drug effects also, interactions maybe that could mimic cardiovascular autonomic neuropathy should be performed, and it's very important. Of course, physiological function of both the sympathetic and parasympathetic nervous system is huge. That's why we have a lot of symptoms and signs from the cardiovascular system, gastrointestinal system, urogenital system, even from pseudomotor system. Let's start from cardiac signs and systems. And of course, I need to remind you that CAN is a significant cause of morbidity and mortality associated with a high risk of cardiac arrhythmias and sudden death for our patients. And they have a lot of clinical manifestation of this complication. It's possible to divide it to some stage, early stage with possible early complication, definitely confirmed complications, severe, advanced, and symptomatic. But the very important issue is that we have diagnostic algorithm for this complication, for resting tachycardia, even for hypertension. If we will talk about gastrointestinal complication, let's divide it to all gastrointestinal complication of diabetes or gastroparesis. Of course, with a lot of signs and symptoms again. We also have some problems with other system, with erectile dysfunction, which huge prevalence, and neuropathy is one of the leading causes of this complication. And also, we need to keep in mind that it's a predictor of cardiovascular events for patients with diabetes. From the point of view from bladder dysfunction, of course, diabetes duration matters. We have a prevalence, and it's very high. And diagnosis should be made by using a validated questionnaire. Pseudomotor dysfunction, it's also important for our patients, and it may result in dryness of foot skin. It also can be a risk factor for diabetic foot ulceration. We need to detect this complication, and we have a quantitative pseudomotor axon reflex test for diagnosis, and some other available techniques. How should we treat this complication? Of course, it differs for each form of this autonomic neuropathy. So we have some treatment for cardiovascular system, for gastrointestinal system, genitourinary system, metabolic. Of course, we need to remember about optimal glycemic control, and even for pseudomotor system. And again, we need to remember the main thought. Recognition and treatment of autonomic neuropathy may improve symptoms, reduce sequelae, and improve quality of life. And it's very important for all our patients with diabetes. To conclude this part, I want to say that DAN is a particular aspect of diabetic neuropathy which leads to multisystemic impairment in both type 1 and type 2 patients. Cardiac system is the most seriously involved. As nowadays no therapy is able to effectively reverse this process, prevention with strict glycemic control, multifactorial intervention, and lifestyle modification remains essential. And again, I want to remind you our main thoughts, our take-home messages for you, The first one is that diabetic neuropathy is a diagnosis of exclusion. Second, up to 50% of diabetic peripheral neuropathy may be asymptomatic. And if not recognized and if preventive foot care is not implemented, patients are at high risk for injuries to their insensate feet. Numerous treatment options exist for symptomatic diabetic neuropathy, and recognition and treatment of autonomic neuropathy may improve symptoms, reduce sequelae, and improve quality of life. Thank you very much for your attention. I hope for a huge amount of your questions during the breaks, during the lunch, during the workshop. And please don't be shy and write me if you need any slides or something. If you use social media, I kindly ask you to follow the official account of EASD. It's EASD News. And if you want to spare your opinion or some comments, if you have some pictures, you just can do it with hashtag EASD Postgraduate Egypt, which is written here. So we will be happy to know your opinion about everything which has happened here. Thank you very much.
Thank you very much, Spasiba. As you heard, we're going to take discussion later on this workshops, or you can interact, and she's not difficult to spot in a red dress there, so you can find her easily. Again, it's my pleasure to introduce a long-standing friend and colleague from Łódź, now Warsaw in Poland, Professor Leszek Czupryniak, who's going to talk to us. He started this session, one says I will start or I'll finish, but he's doing both. He's finishing the session talking about hypertension. Leszek, please.
Okay, I try to be brief, just not to extend our session too long, because there is another session after hours immediately. This is a very important topic at present, because I mentioned yesterday, just 2 days ago, American College of Cardiology with 2 other American associations accepted new guidelines for hypertension treatment, and there is a short passage on diabetes there. I will mention it also here, but it also means we will be reopening the discussion on the target treatment in diabetes as well. It is important because that's pretty obvious. We measure, or the patients measure, blood pressure, and upon this, as Professor Boulton mentioned, just single or just a couple or 3-4 measurements, we make the decision to introduce or not introduce or intensify the treatment. So it's all quite important. The clinical rule really is that anyone who has diabetes almost certainly has hypertension. This is one of our studies we did over 10 years ago in Łódź, in the city where I live. We enrolled into the large population study, over 2,000 inhabitants of the central district of this city, and in a group with patients with newly diagnosed diabetes, and the patients who, or the subjects who had no idea whether they have or no diabetes, we measured, we assessed blood pressure, and what we found out, which you can see here quite clearly, is that the moment of diabetes diagnosis, on average, people have their systolic blood pressure higher by 11 millimeters of mercury, comparing to age and gender matched non-diabetes, non-hypertensive peers. So immediately diabetes at least doubles the risk of developing hypertension. Why is it so? I could show you a number of pathways leading from hyperglycemia to elevated blood pressure. This is the picture I drew some time ago, and it is still valid. There are a number of pathways which causes patients with diabetes having or being susceptible to hypertension. One is obesity. And in obesity, hyperinsulinemia is common, and insulin activates sympathetic nervous system, which increases cardiac output and also leads to sodium retention. Insulin itself is a very powerful sodium and fluid retention hormone. So that itself increases the volume of the blood, and it's one of the main mechanisms behind hypertension development in patients in obese people in general. Hyperglycemia, of course, damages kidneys, which we've just heard, and that affects affects the regulation of water and electrolyte balance, also leads to sodium retention. Hyperglycemia activates renin-angiotensin-aldosterone system, which also increases blood pressure. High blood glucose, high blood glucose damages endothelial cells, and endothelium is the most important source of nitric oxide, which is in turn the most powerful vasodilator. So if there is no vasodilator, again it leads to high blood pressure. We have autonomic neuropathy developing in the course of diabetes, which impairs the regulation of blood pressure decrease overnight. And in healthy people, the blood pressure drop at night should be at least 10%. In practice, it is even 20%, and it disappears in diabetes very often. Also, we see the patients in whom we use 24-hour blood pressure monitoring a reversed blood pressure pattern, so blood pressure at night is higher than during the day. That increases blood pressure load and also contributes to hypertension. And the final really crude pathway is formation of advanced glycation end products, which increases arterial stiffness and elevates mostly systolic blood pressure. So having this 1, 2, 3, 4, 5, 6 of different pathways, it's clear that people with diabetes cannot escape from hypertension. And if you see a patient with diabetes who has normal blood pressure in your office and is not taking any medication, you should be suspicious, because perhaps it's the case of so-called masked hypertension, which is a reversed hypertension, a reverse situation to white coat hypertension. The patients have lower, not higher, blood pressure in the office, which probably means that the world outside your office is even worse for them than the one they experience when they visit you. So no wonder when we treat diabetes, we concomitantly prescribe hypotensive agents, and we are as good diabetologists as hypertensiologists at the same time. When we started really to pay attention to hypertension role when STENO2 study results were published. There is the first author of the series of STENO2 papers. Peter Gade is a very good friend of ours and participant of our courses very frequently. This was the first study, actually, a small study, 160 people only, but this was the first study which showed that if patients were treated in a multifactorial fashion, the risk of developing of need for PCI or coronary artery bypass grafting, or the risk of stroke, or even MI, was lowered, even if it did not reach statistical significance. But on average, the patients in multifactorial intensive treatment group had about 50% decrease of musculovascular complications development. And if you compare it to UKPDS, when the authors, investigators were able to show the famous 16% reduction with 0.052 statistical significance, the STENO2 results were much more impressive. So how it was achieved? The study was designed in that fashion that there were a number of targets to reach, but not just in relation to glycated hemoglobin, but also in terms of blood pressure, lipids. Patients were also taking ACE inhibitors as a regular treatment, aspirin therapy, and vitamin E at the very beginning. They later stopped using it. And this was the target for blood pressure, 130/80. And because of the impressive results of this study, that after a few years of treating patients wanting to achieve these targets, they had by half decreased risk of macrovascular complications. 130/80 was accepted in the guidelines of almost all national and international associations, and we were told for about a decade that this is the target of blood pressure we should achieve in all our diabetes community. Especially, this was strengthened by further analysis from UKPDS, because if they looked carefully what was responsible for this impressive risk reduction in macrovascular complications, only in 2 out of these 5 targets, statistical significance was achieved between intensive and standard and conventional therapy group. It was cholesterol, total cholesterol. Patients in intensive therapy, they had it significantly more often lower than in conventional group, and systolic blood pressure. If you look at HbA1c control, this was really not impressive at all. Even in intensive therapy group, only 15% of patients reached the goal of 6.5%, while almost no one in conventional therapy. And the difference here did not reach statistical significance. So the major driving force behind this risk reduction was not glucose control, but it was blood pressure reduction and cholesterol reduction, and these were the patients with microalbuminuria. So this is also important. They were not newly diagnosed patients, they already had some signs of end organ damage. So that strengthened the message. 130/80 was largely accepted. The second, or the additional element in this understanding of blood pressure lowering importance came again from the UK PDS, but observational part of the study, where the study was terminated in its active phase in 1998. The results were presented in Barcelona almost 20 years ago, but then the patients were followed for the next few years. And the blood pressure arm in UK PDS, the patients achieved less, there was arm for tight and less tight control. The difference was at the end of the study 10 millimeters of mercury of systolic and 5 millimeters of diastolic blood pressure. When the study ended, then as you can see, the blood pressure simply converged. There was no longer, this difference was not maintained. Both systolic and diastolic blood pressure somehow migrated to the mean, you might say. And what was also seen concomitantly, that this loss of difference in blood pressure also translated into the loss of the decreased risk of microvascular complications, for example, in diabetes. After 2-3 years, the patients lost the protection which they had when blood pressure was lowered in a tight control group. And that's any diabetes-related endpoint the same. There was a decrease in patients with tight control group, but it disappeared over the course of the time when blood pressure difference also disappeared. And why it is important? Because if you compare it to the results seen in a glucose control group, the patients who were intensively treated and then this treatment somehow deteriorated in the observational phase, they still remained protected in terms of, for example, all-cause mortality or diabetes-related endpoints. This study helped to formulate the hypothesis of a sort of legacy effect of glucose control, that it's especially important in the first decade of the disease, but also showed that in blood pressure control there is no room for any stopping of the intensifying of the treatment. Once we start treating blood pressure, we should continue, we shouldn't stop, because any beneficial effect will not remain. It will disappear once the patient stops taking the medication. That lowering blood pressure is beneficial has been, after UKPDS and after STEAM-02, confirmed in a number of studies. This is a meta-analysis published in JAMA only 2 years ago, one of the largest ever published on blood pressure lowering effects in type 2 diabetes. That if you look here, each of these studied elements, be it mortality or detailed complications of diabetes, there is always a benefit. Perhaps in renal failure it did not reach statistical significance, but the tendency is clear, and overall we have a very nice risk reduction when we lower blood pressure in diabetes. There were even arguments at some time that in blood pressure, because the risk is so high, the blood pressure should be lowered even more than in people without diabetes. And then if we look at the guidelines from 2013 from European associations, hypertension, cardiology, they are still valid. The new one are being prepared and will be published very soon. They said that when we analyze everything, if you look here, actually the recommendation should be 140/85 in people with diabetes. So this was somehow raised from 130/80 to 140/85. This came as a surprise. This came about not even 10 years when, around 10 years after Steno study was published and influenced this target 130/80. And this was controversial because many cardiologists say, well, it's not a wise decision because we will miss treating hypertension at all in many patients. We'd rather have more stringent targets even if we cannot achieve them. But the authors of this paper, they recommended, as you see here, that's in patients with nephropathy, lowering systolic blood pressure again below 140. With overt proteinuria, it could be 130. But the authors of this paper argued, well, the target of 130/80 is not really documented. It was the goal in the Steno study, but no one said it was achieved by all the patients in whom the benefit was seen. And if they took many studies together in one line, you can see that the yellow part of the bar shows the decrease in blood pressure, that actually only a subgroup of ABCD study brought the systolic blood pressure below 130. In all other studies, it was never, that low level of blood pressure, 130, was never achieved. So they said, okay, 130/80 is not evidence-based, probably only 140/90 is enough. And it was also confirmed, this point of view, by the Accord blood pressure arm in the Accord study. This was the study which changed our thinking about glucose control. We now talk about individualization of the therapy. I will be talking a little bit about it tomorrow, about goals of diabetes treatment. But what they did in the Accord study, in the intensive there was a separate arm. Patients were also randomized in terms of intensive and standard blood pressure treatment. And they achieved a wonderful result, because the difference here between standard and intensive study group, you can see it's like 15 millimeters of mercury, very impressive. This was achieved by using on average over a 1 pill more for blood pressure lowering than in a standard therapy group. This is the number of prescribed drugs, and more or less it's over 1 agent more used in intensive group. And the reduction, the difference here is impressive, highly statistically significant. But it all came for nothing, because in these groups with lower blood pressure, there was no effect on primary outcome of the study, non-fatal strokes, non-fatal myocardial infarctions, or cardiovascular death. The patients were dying equally often whether they had lower or higher blood pressure. So the conclusion from all this was, yeah, we don't have to strive to 130/80, 140/90 is enough. And we somehow accepted it quite easily, on the other hand, because it simply didn't put additional burden on us as doctors to require the patients to have lower blood pressure. So how we were told to achieve this target, just a few sentences about the treatment. This is still a valid guideline for the management. Patients with diabetes are usually in this category. They're at high or very high cardiovascular risk. We should start with 2-drug combination, usually at not maximum doses, and then we should add a 3rd drug. And the drugs we should be used are all written, the groups are written here. This is a very nice diamond which shows the 5 main groups in hypertension treatment. Not much happens in hypertension pharmacotherapy, by the way, when you compare it to diabetes pharmacotherapy. One combination is clearly contraindicated, ACE inhibitors with ARBs. It's just, there are too many side effects and not enough benefit, but we can use any of those drugs actually to treat our patients, with a clear preference in this document from 2013 of either ACE inhibitors or angiotensin receptor blockers as first-line agents, which we all know very well. So we followed this diamond, I guess, and also in the guidelines, apart from these drugs, what is worth remembering, We should also remember about old drugs like alpha-1 antagonists. The good old doxazosin is often used, especially in men with prostate hypertrophy. We quite often use clonidine in centrally acting agent. In pregnant women with hypertension and diabetes, methyl-dopa is a drug of choice. And we also use some newer agents, also centrally acting, moxonidine, from time to time. And what has really changed hypertension treatment is the ability to use the fixed dose combinations with 2 or 3 agents. If you travel to India, they are famous for having combinations of all possible drugs in one pill. Now we use in Europe more often even 3 drug combinations, like ACE inhibitor with calcium channel blocker and a diuretic. So there is plenty of options. Actually, the choice of the drug for hypertension might not be that straightforward. And some of our patients needs multiple medications. My record patient takes 9 drugs for hypertension. Almost everything we could think of we use for her because it was so difficult to treat it. We studied her, we looked for for primary causes for hypertension, found nothing. And together with nephrologists and hypertensiologists, we designed a 9-drug therapy. So that's also possible. But you might also remember about simpler issues. I'm just showing you the case we described 10 years ago about a lady, 63-year-old lady, who she was my patient. She came to me, and just a regular patient like many others. And she came to me 8 months after a stroke, and it was kind of surprising because previously she was not treated for hypertension. And in the office, her blood pressure was 190 over 110. And what we discovered during this visit, that after the stroke, she developed the severe dysgeusia, whatever you call it. It means she lost her appetite. She lost not appetite, she lost her taste. And to make their food palatable, she used enormous amounts of salt, up to 110 grams of salt per day, as we assessed it. So 1 kilogram of salt she used within a week. So that generated severe hypertension, and all we did is we asked her to stop using salt, suffer a few more months until her taste came back. It came back, not as much as it was before stroke, but it came back. So sometimes just high salt intake might be the cause of hypertension in our patients. But this is this document I mentioned yesterday and today. This is this 2017 ACC-HAA blah blah blah. You can see so many American associations, guidelines for the prevention, detection, evaluation, management of high blood pressure in adults. You can get it for free in American Cardiology College, American College of Cardiology webpage. It's 197-page document. So if you have nothing to do, you can read it thoroughly. It's a compendium. It's a really a manual on all these things about hypertension. And what they say about diabetes is summarized in this simple table, which I guess you see for the first time here. What they say is just 3 short points. In adults with diabetes and hypertension, the drug treatment should be initiated once blood pressure exceeds 130 over 80, and this should be the goal of the treatment. There is little explanation why they decide to advocate it, but they say, well, the studies where 140 over 90 was based on their old studies. The same argument I mentioned already today, like HOT study, ABC study, used patients with diabetes which was diagnosed much later at 140 milligrams per deciliter cutoff, not 126 as it is today. Also, the newer data advocate going, to put it very briefly, lowering target to 130 over 80. The second recommendation is also interesting, and it's a relatively high level of evidence. SR means systematic review here. LOE means level of evidence, but it's a recommendation of the highest level here. And they also say in adults with diabetes and hypertension, all first-line classes are useful and effective. So in a way, ACE inhibitors and ARBs lost the recommendation to be used as first-line agents. So that's a second major change introduced by the Americans, with one exception for these two groups of drugs. They might be indicated once someone develops kidney complications like albuminuria. Other than that, any drug which will lower blood pressure to 130/80 is good enough to be prescribed. So I think you can imagine what will happen now. It's November. In January, there are new standards of care published by American Diabetes Association. So it's interesting whether they adopt it or not. Probably they will. And then other associations as well. This has already been commented upon in in general press in US, that just by lowering this target, the number of Americans with hypertension from 1/3 of population will increase to half of population. And the same will apply to all of us. So, as much as the title of my talk sounds pretty innocent and might be boring, actually I guess it introduced the reopening of again heated discussion, and again we will be required to change our practice. I'm quite convinced the world will follow 130/80 recommendation. And finally, that's my final slide when I talk about blood pressure and lipids. It's an old picture, but somehow I couldn't find a better one. If you imagine that a patient with diabetes is this gentleman in white shirt, this picture was painted by the Spanish painter Goya over 200 years ago. There are Napoleon French soldiers killing Spaniards, participants of uprising in Madrid. This is Madrid Cathedral. But you can imagine that with all due respect and proportions of the picture, our patients are attacked by hyperglycemia, but equally enough by hypertension, hyperlipidemia, smoking, which has already been mentioned by Professor Boulton. We're a little bit amazed with this. Even here you can feel the cigarette smoke in the air, and probably any other pathologies which are hidden somewhere here, which we probably might not even detect, let alone treat it, attack our patients. So if we manage to control at least one of them, we will increase the chance of our patient to survive. Thank you very much for your attention.
Thank you very much, Leszek, for a succinct overview of a complex area. We are running rather late, and I know that Leszek has a workshop tomorrow afternoon. I'm sure he'll be happy to answer questions on hypertension. Rumour has it that there may be a photograph now. Is that true? Does anybody know? Yes. Oh, okay. We will now move on to the next session, and the photograph will be at 5 p.m. or more likely 5:30 p.m. looking at the watch. Okay, thank you very much to everybody, and I'll hand the chair over to the next chairpersons.